Welcome to the Catalyst Podcast. I'm your host, Charles Epstein. Several months back, we were joined by Chuck Ingoglia, the CEO and president of the National Council for Mental Wellbeing, for an excellent and informative conversation on the organization's advocacy work. Today, I'm joined by Peter Delia, the Council's federal policy and advocacy strategist. Peter was previously senior attorney for the Florida Senate and the assistant attorney general for the Florida Office of the Attorney General. Peter, welcome.
Charles, thanks so much for having me. Excited to chat today.
Yes, indeed. And you are calling in from the other side of Florida, Tallahassee, yes?
I am. I'm your neighbor to the north. That's right.
Absolutely. So today we're going to focus on the so-called One Big Beautiful Bill Act, specifically the Medicaid provisions, its implications for mental health, and what the National Council for Mental Wellbeing is doing to mobilize opposition and raise awareness. Peter, first, I need to ask you, what prompted you to go from your work in Florida state government to the National Council?
Well, Charles, I worked in state government for about 10 years, and about 5.5 of those were with the Florida Senate, working specifically on behavioral health policy issues at the state level, right? Drafting legislation and doing that kind of thing. And so much of what I was doing really kind of stemmed from federal initiatives. So, so much of it was tied into Medicaid, for example. And I had to kind of learn all this stuff about federal health programs that were really driving the policy that we were creating at the state level. And after a while, I kind of said, well, I think I want to work directly on this stuff because I feel like I'm only seeing part of the picture here, right? I mean, I love doing state policy work. I miss so many parts of it to this day, but I always wanted to gain some experience doing federal work and having that broader understanding. And it's honestly just been a blast so far.
But you're sort of now on the other side looking in.
Yeah, exactly. It's a different perspective, but it's so interesting looking back on the work I did now, having this broader perspective and this, different understanding of everything that's going on at the federal level. It's been really interesting.
Yeah, I guess you had to have had some experience in the sausage factory to understand it at a deeper level so you can come at it from that outside perspective. Before we get into the OBBB, easy for me to say, tell us about your day-to-day work with the National Council.
Yeah, absolutely. So, a lot of what we do is kind of staying on top of developments in federal behavioral health policy, interpreting them, and then kind of providing sort of a more just simple and plain language interpretation for our members, and then kind of helping our members understand how they can be prepared for whatever it is that's coming, whether it's an opportunity or a challenge, right? Helping our members understand best practices, their best course of action, what all of these things mean to them. That's a big part of it. Our policy team, in terms of what we do, we draft legislation, right? We draft federal legislation. We have a state policy team as well that works on state behavioral health initiatives. We engage in a ton of advocacy efforts. So we do things like action alerts for our members, sign-on letters encouraging members of Congress or federal agencies to either do something or not do something, right? And then we also talk to our members a lot. We provide them with updates through, regular calls, meetings. We go to their annual meetings. We give updates and we answer questions from their members, right? Because we have some members who are state behavioral health associations and all of their constituent members are also our members. So we'll go to their states, give federal updates and make the connection for them to show how what's happening at the federal level impacts their work at the state level.
Yeah, it's quite a few moving parts.
Just a few.
Yeah. I threatened to make this conversation about the One Big Beautiful Bill Act, which, as many of our listeners probably know, was signed into law on July 4th, 2025, and it contains hundreds of provisions related to taxes, government and spending and social programs, with various components taking effect at different times. But of course, for today, we want to focus on the spending cuts to Medicaid and its implication for mental health and substance use disorder and the work your organization does. First, tell us how we got here, and we can talk about everything from reconciliation. You can go as deeply into the weeds as you like.
Sure. Well, that's a dangerous thing to say to me, Charles. But
I can imagine.
but we've been sort of saying something like HR1 was at least a possibility really since this time last year, basically. In the election last year, we saw Republicans achieve what's called kind of colloquially a trifecta, which is when one party controls the presidency and both chambers of Congress. The last time we saw this same makeup was in 2016 into 2017. And we saw an attempt at that time to make some of these big changes to Medicaid. They were unsuccessful then. But basically, right now, you've got Republicans with slim majorities in both the House and the Senate, right? In the Senate, if you have less than a 60 vote majority, you're not going to be able to get much done unless it's bipartisan or unless you use the reconciliation process. The Senate has something called the filibuster rule, which basically makes it so that you need to get 60 votes to move things unless you've got buy-in from enough members of the other party. So with reconciliation, you can pass policy if you've got a simple majority, if you've just got 51 votes. Republicans have a 53 to 47 majority in the Senate right now. So what they ended up having to do was use the reconciliation process. And it's a very convoluted process, which takes several months to play out. It really the first discussions about what it might contain began in January. And a lot of what they wanted to do was extend tax cuts from 2017. And to try and pay for that, at least partially offset some of the costs there, they wanted to look at changes to entitlement programs, really specifically Medicaid, right? So we started seeing, we saw what was called a menu of options from the House of Representatives for different changes they could make to Medicaid back in January. And we saw some of the things that eventually made it into the bill in that menu of options, they call it. Not everything, but a lot of things. And so that's kind of what happened. We ended up starting the reconciliation process early last year, and then it culminated in, the so-called One Big Beautiful Bill Act that passed on July 4th.
One thing I do want to ask as far as reconciliation, my understanding is that only certain type of bills are subject to reconciliation. It has to do with taxes. Is that correct?
Yeah. Basically, taxing and spending are the main things you're going to be looking at there. And reconciliation, I think sometimes, people confuse it with the broader appropriations process. When it comes to the type of spending that can be dealt with through reconciliation, it's limited to your entitlement programs, right? To your Medicaid, your Medicare, CHIP, Social Security. And then the appropriations process handles discretionary funds. So things like your SAMHSA grants and programs and pretty much everything else.
Okay, so you establish in broad strokes what the implications are for Medicaid. Let's get a little bit deeper into what each provision will do and when they will take place.
I think kind of the first couple of provisions that folks are looking at right now are number one, work requirements, and then also eligibility redeterminations. Okay. So just big picture, what are some of the changes that we're seeing around work requirements? Well, work requirements are going to take effect January 1, 2027 for all 50 states. And folks in Medicaid expansion specifically, this is as many provisions in HR1 are, this is specific to the expansion population. So anyone in the expansion population is going to have to complete either 80 hours of work per month, 80 hours of school, a work program, community service. I think there are a couple others as well, but those are the big ones. So those will have to be done 80 hours a month starting January 1, 2027. Eligibility redeterminations. That starts the same date, January 1, 2027. And what's changing there is right now, eligibility redeterminations take place every 12 months, right? So again, specific to the Medicaid expansion population, beginning January 1, those are going to take place every 6 months, okay? So those are kind of two of the biggest changes that are happening most immediately, I would say. Looking a little bit further out, October 1 of 2028, there are new cost sharing requirements that are going into place. And those are going to be, once again, for the Medicaid expansion population. And folks will have to pay between $0 and $35 for copays, for premiums, things like that, when they receive services. Now, there are all kinds of exceptions built into several of these provisions, right? There are exceptions for individuals with what they call a disabling mental disorder or a substance use disorder to the work requirements. And right now, I think kind of one of the big questions is what those exceptions are going to look like in practice. There's no federal definition, for example, of a disabling mental disorder. So CMS is going to have to step in and provide at least some guidance on what those terms mean. And one big question is how much discretion is going to be left to the states to sort of fill in the blanks and figure out exactly how those exemptions work in process.
I want to dig a little bit deeper into that in a moment. But as far as the work requirements that are going to kick in, the 80 hours per month, I'm assuming that a number of recipients already clear that hurdle. So what percentage are going to be affected? Do you have that number at your fingertips?
I don't have it at my fingertips, but I know you are correct that most of the folks who can work already do work, right? And so I think, one question that we have is if you are working, is that going to be captured adequately, right? Are we going to be able to have state Medicaid agencies look and say, okay, this person is working, they're meeting the requirements, or are they going to kind of get lost in the administrative requirements of the bill? Are states going to be able to process folks correctly? One thing we're hearing from some of our members in conversations they've had with state Medicaid officials is that the data systems and the IT infrastructure that's currently in place in a lot of states might need to be upgraded, in some cases, really significantly. We've heard that in some states, the infrastructure hasn't been updated in almost 3 decades, right? So that's certainly something that I think is on the mind of both state leaders and clinics and state associations. I think a lot of folks in this policy space are also just trying to take things one step at a time and focus on what they can. But, those are some of the considerations around work requirements specifically that folks
Yeah.
are worried about.
I think the other implication or impact is not just capturing it, but anytime you add some onerous other things to do, 12 months, now it's 6 months, people are not going to comply. They're not going to be mindful of it, and they're going to be lost. And I'm assuming lose those benefits as a result. Yes.
Yeah. Yeah. I mean, that's a big part of the problem is, are folks even going to know about this, right? So that's why I think things like outreach at the community level from clinics and providers and partnerships with schools and with, places of worship and things like that are really going to be key too, to just get the word out as much as possible.
Yeah, you already sort of touched on this, but how will these Medicaid provisions affect or limit access to mental health and substance use disorder care?
Well, I think one thing that's kind of important to remember at the top is that Medicaid right now is the number one provider for about, I think, 25% of mental health services in this country. And then as much as 60%, depending on how you find it, of substance use disorder care, right? And so I think that kind of just big picture shows you how much of a role Medicaid plays for individuals with mental health and substance use conditions, right? And I think, as we kind of talked about, there are these specific parts of different provisions that explicitly address mental health and substance use, like those exemptions I mentioned for community engagement requirements. So I think one thing that we worry about is a lot of times, even though a lot of folks are working, as we talked about already on Medicaid, folks sometimes need mental health and substance use care just to be able to work, right? Just to be able to do what they need and get a job and, be a productive member.
So it's very much a chicken and egg in some cases.
Exactly. Yeah. So that's part of our concern too.
So tell us about your advocacy work in this particular area. What resources are you mobilizing, and what's your overarching strategy?
So, I can't say enough about the work that our members have done this year in the advocacy space and that all of our advocates have done, really. We have had over 40,000 calls, letters into Congress around, mostly a lot of it was around HR 1, but not all of it, just around everything in general, 40,000 calls. We've reached every member of Congress. And I think even though we didn't actually see HR 1 get defeated in Congress, we did see some pretty big result of our advocacy. We saw those exemptions I mentioned for work requirements that are specific to behavioral health. With the cost sharing requirements that are going into place, we saw not just exemptions for mental health and substance use, but we saw facility specific exemptions for certified community behavioral health clinics, CCBHCs, for federally qualified health centers and rural health clinics as well. And we also saw in the Rural Health Transformation Program, that's the $50 billion relief fund intended for rural providers in the bill. We saw CCBHCs, opioid treatment programs at community mental health centers, all as a part of the eligible facility types for the program, eligible to receive those funds. So just kind of speaking in terms of what our advocacy has done so far, I think it's really, really been impactful, especially this year. In terms of what we're going to be doing going forward, around HR1 specifically, we have a lot of stuff planned. One of the first things that we're doing is we're getting a member survey. We actually just got it off the ground this week, and we're collecting data on things like the amount of uncompensated care provided, whether you've got a wait list, how much of your funding comes from federal sources. It's about, I think, 22 questions, kind of just covering a gamut of information. And what we're hoping that'll do is provide sort of a baseline for where folks are at right now. And then we'll reconduct the survey again, a year from now, 2 years from now, once different parts of the bill go into effect, and hopefully get a better sense of how the bill is impacting providers and clinics. And then we'll use that to shape our advocacy efforts going forward. So that's part of what we're doing. We're going to hold a webinar series on the bill. We're going to have one webinar around each major Medicaid provision, essentially, kind of ruled out shortly before they go into effect, a few months before. We've got that started already. We've got one webinar out there on the Rural Health Transformation Program. So we're going to keep that going as well. But that's just kind of a small taste of what we're doing. We've also got our Action Alert Center where folks can go and sign up for our action alerts. So basically, anytime there's something coming up like a big bill or a rule or regulation that we think is worth either supporting or asking your members of Congress to take action against, you can sign up, get those alerts, and what you'll get is essentially the opportunity to send like a pre-written letter that you can customize if you want directly to your members of Congress. So that's just kind of just a sampling of what we've got going on in the future.
Quite a lot of activity for sure. Peter, talk about some of the ways organizations could mitigate impacts outside of advocacy.
Yeah, absolutely. So I think it's helpful to kind of look at low-hanging fruit to start, right? So for example, to the extent possible, providers want to maybe focus capacity on where disruption could be the most likely. So, this could mean things like identifying patients that are most at risk of losing coverage and flagging them like in electronic health records for reminders and things like outreach and support. Some other low-lift tools that come to mind, enhancing existing patient outreach strategies. So things like text blasts, reminders built into scripts for clinicians and other staff, questions for patients during their intake paperwork that could indicate that, they may be at high risk of losing coverage, whether that's because of a possible loss of employment or anything else, really. That's something to try and take a look at. Things like signage and lobbies, letting patients know about changes and requirements. And then I think also working with health plans, doing things like developing training materials, establishing channels for communications with like care navigators, all to kind of ensure that the folks who are at the greatest risk of losing coverage don't fall through the cracks. And, again, those are all just sort of very basic, hopefully easy lift type activities providers can take. We're trying to help our members out in this regard as much as we can. Like I said, we've got a number of resources coming out, and we'll continue rolling those out in the coming months and weeks.
Excellent. Let me end by asking you a personal question. So much of your work seems Sisyphusian. Did I pronounce that correctly? Sisyphusian.
That's how I would pronounce it. Yeah.
That's how I would pronounce it too. And that's how I did pronounce it. So, well, we're going to go with that. It's very hard to plant your flag and declare victory. Every day it's a battle, and I'm not sure you can ever declare victory in this ongoing effort. So what keeps you going? What makes you get up every day ready to dig in and do your work?
It's a great question, Charles. I think for me, it is difficult sometimes to plant a flag and declare victory, but at the same time, we do see a lot of little victories along the way. So many times, really, we do, as I mentioned earlier, a lot of presentations for our members, a lot of federal updates. I can't tell you how many times I get feedback, just saying, thank you so much for just telling us what all this stuff means, just helping us to make sense of it, because so much of it is coming at us so fast and furious, and so much of it is convoluted and confusing. So even just those little just emails I get after a presentation or something like that for our members expressing so much gratitude, they're so appreciative and they work so hard. The work our members do is just so incredible. And so I think little things like that, but then also bigger things too. I mentioned some of those exemptions that we were able to get into HR1, right? For CCPHCs around cost sharing. And, as members that can receive funding from the Rural Health Transformation Program, those are big achievements. Those are things that really matter to our folks because it will ensure that the folks who most need care will continue to receive it. And that's the biggest part of what we do. It's just making sure that happens every day.
Yeah, excellent. We're going to have to check in with you sometime next year, hear about some of the progress you've made in your amazing and tireless advocacy work, you and the entire organization. Peter, really appreciate your time.
Charles, thank you so much. It was really a pleasure to be here.
Same. Today, I spoke with Peter Delia, Federal Policy and Advocacy Strategist for the National Council for Mental Wellbeing. He joined me today from the other coast of Florida, Tallahassee. This is Charles Epstein for the Catalyst Podcast. Thanks for listening.